So let's begin the last session. It's my pleasure to chair this session with Loren. And in this session, we will talk about, again, the ELAACC registry. Yeah, the ELAACC score. So we come back to the origin. I mean, in the first meeting, we talked about this, and now let's see what we have done and what we are going to do. So, Adel.
So I think it's going to be a nice session because we will talk about the score, but also how to go towards a clinical validation of this score. I think it's very important. So these are my disclosures. So just to the people that are not still aware about this classification, so you know that the LAACC remains challenging. It's a challenging procedure due to the extreme variability of the anatomies of the left atrial appendage. And that necessitates some kind of accurate classification to guide the implanter for an optimal procedure planning. And so the classical, well-known anatomical classification, like cactus, cauliflower, chicken wing, windsock, actually just provides a visual understanding of the morphology, but we thought that it lacks specificity in predicting procedural complexity and potential complications like peri-device leak, device-related thrombus, embolization, and so forth. And so there was a clinical gap, and there was a need for a novel and more pragmatic classification for the implanter, which would integrate essential anatomical and functional details that can influence the choice of the device, planning of the procedure, and the management of the risk. So you look at this appendage, for example. Okay, is it complex or is it not complex? And look at those appendages. So definitely on the right of the screen, you see extremely more complex appendages as compared to the left side of the slide. And that's okay. You just say, okay, visually it's more complex, but you don't have like some anatomical parameters to quantify the complexity. And so we published this classification, and this was done by the ELAACC board with 11 experts from 9 European centers. We developed this classification based on a structured consensus and voting. And remember, this was presented, all the parameters were presented during the first ELAACC meeting. So we wanted also this system to be comprehensive, easily integrable into daily practice, and useful for distinguishing between standard and more complex cases. So a criterion was included in the classification only if more than 50% of the board members voted yes, ensuring some kind of true consensus. Although now we say that it's 2/3, but at that time it was 50%. And the final classification integrates 5 key anatomical and functional parameters. I will very quickly redefine those parameters. So the entrance, the landing zone, the anatomy, the axis, the contraction, yielding at the end 12 binary criteria, yes or no, that categorize LA anatomies. So one important step also, because it was to define some clear anatomical landmarks. So we have given a clear definition of what was the LA ostium, and the plane where the appendage opens into the left atrium. So we define it as a virtual line connecting the inferior LA margin, just proximal to the circ, and above the mitral valve, of course, and to the super LA margin, with the ostium plane being perpendicular to the central axis of the neck. And on the 3D MPR view, it can include or not the Coumadin ridge. So, I mean, if you come back, it can include or not the Coumadin ridge. And based from this anatomical ostium that you need to define first, you can have the working depth, the Coumadin ridge distance, and the presence or not of an early sharp bend, as I will show here. So the entrance, the definition was a LA ostium diameter of more than 35 millimeter, and every time we tried to figure out what will be the potential challenges. For example, here it was challenging in terms of device sizing and also increasing the risk of peri-device leak. And then there was the fact to have a long pulmonary vein ridge, which was defined as a ridge extending more than 10 millimeter from the anatomical ostium, and that could, as a consequence, have an unclear, not well-defined ostium, and also increasing the risk of device-related thrombus, which has been shown in the CHAVI registry. Also, the fact to have a low position of the ostium, a low takeoff, which was defined as an inferior LA margin within 5 millimeter from the mitral valve annulus, and this we thought that this could create some issues with catheter alignment and mitral valve interference. And then there was a landing zone. There was like 3 parameters. The first, no, 4 parameters, sorry. There was the large dimension of the landing zone, so more than 30 millimeter. The same difficulty with device sizing and risk of peri-device leak. Extremely eccentric landing zone. And also we give here a cutoff when you have the ratio between the maximum diameter and the minimum diameter of more than 1.5. And this creates some difficulty for device sizing, conformability of the device, and also peri-device leak. The fact to have a proximal lobe that could lead to an uncovered proximal lobe, challenging for a single component device. And also the fact to have a protuberance or any kind of proximal bifurcation, also with a clear definition. And also this can lead to improper device engagement, stability issues, and so forth. Then the anatomy, so the fact to have an early sharp bend, which was defined as a bend within 10 millimeter from the ostium with a very acute angle. So this can create difficulty for implanting the device on axis. There was also the definition of a short working depth, which can also have impact on device stability and the risk of embolization. And finally, the funnel shape, which also we have given a clear definition, like a LA ostium to landing zone diameter tapering of more than 30%. The axis, so pronounced anterior or posterior deviations, which could also give issues with device and catheter manipulation. And the final one was the contraction, so having a very hypercontractile LAA, which was characterized by diameter changes greater than 50% during the cardiac cycle. This was supposed to be associated with the highest risk, the higher risk of erosion and device embolization. So we ended up with 12 characteristics, 1 point for each. And we just proposed a color-coded system when we say that the challenging case will be like the combination of at least 3 of those parameters. When you have nothing, it's a simple case, and when you have 1 or 2 parameters, it's going to be a moderate case. But this was not validated, of course, at that time. We did a very small epidemiology of those parameters. And you can see that the distribution, at least 1/5 of this population had a challenging score, like more than 3, moderate 42%, and simple 1/3 of the patients. Just give very quickly some examples. A case, for example, with the proximal lobe, when we decided to implant the Watchman. In this case, so despite repositioning of the device, you can see that the proximal lobe was not covered by this specific device here. In another case, you can see combining many of those parameters, so short depth. You can see that also a long Coumadin ridge. You can see that the ostium is extremely large, it's very eccentric, and so you end up with a very high score here. And when you look at the simulated simulation by Phelps, you can see that really it's very difficult to place this device into this case. So you can really anticipate the complexity of this specific anatomy upfront using those parameters. But the ELAACC score is based on expert consensus, so a structure that inherently is subjective. So we need a prospective clinical validation, which is currently lacking, but Lorenz will give some insight. So the K unanswered questions, those are higher ELAACC score independently predict complexity. Does the score predict specific complication, like PDL, DRT, embolization? Is the score reproducible across operator and centers? Do some of the parameters carry equal weight, or should they be weighted differently? Does the score perform differently depending on the device used? These are a lot of questions that we still need to answer. And though we need a large-scale, multi-center prospective data to address this problem. Also, just a glimpse into the talk of Lorenz, what will be the primary endpoint? Is it going to be like the procedural complexity? Could it be procedure duration, number of catheter exchanges, number of device recapture, so the procedure efficiency or the need for a rescue strategy? Or do we go for like secondary endpoint or not? Or what kind of secondary endpoint also we can try to anticipate with this classification? For example, the risk of acute complications, pericardial effusion, tamponade, embolization. Should we go for mid, long-term outcomes? And also imaging endpoints. So we need to also have a clear concordance between TE and CT, and to address the inter and intra-observer reproducibility. So we need this multi-center registry. I think the ELAACC registry will be the ideal platform. And what will be the target population to validate? We don't know actually. So is it like more than 1,000 patients? How many centers? To have enough power to detect the association between the ELAACC scores and the complexity. So the ELAACC score provides a structured 12 criteria implanter classification to address the LA anatomy complexity based on an expert consensus. The prospective clinical validation is needed, and so a future multi-center ELAACC registry is the natural step to validate this score. Thank you very much.
Thank you very much, Adel. We continue with a first attempt towards the validation of the ELAACC score, and Victor Eskildsen from Aarhus will present on the reproducibility of the ELAACC score. Thank you, Victor.
Thank you very much for the presentation, and thank you to the ELAACC committee and to Jens Erik for inviting me to give this talk. And could we have the slides on? Perfect, thank you. And in this first talk, I would like to focus on the reproducibility of the classification. And our efforts in this field has led to the production of a study that we hope to see published in the near future on the reproducibility of the ELAACC anatomical classification in the field of procedural computed tomography. And this study was conducted in parallel to the clinical validation work that we will see presented later in this session. And the design of our study builds on the original work by the ELAACC group that we just heard presented by Adel. And the work was, of course, centered around defining an implanter-based anatomical classification. And as we see highlighted here in the central illustration from the original paper, we see the 12 binary characteristics and the color grading for the ELAACC score. And our study was conducted as a dual-center cohort study based around independent imaging analysis by 2 blinded raters of 800 consecutive pre-procedural CT images. And patients were, first of all, the sample size of 800 was based around a power calculation performed for subsequent clinical validation, but patients were included in a one-to-one fashion by the Inselspital in Bern, Switzerland, and Aarhus University Hospital of Denmark. And we saw included patients with a comparable distribution of age and sex, and an average CHA2DS2-VASc score prior to procedure averaging around 4, with the Swiss patients having higher rates of congestive heart failure and also vascular disease prior to procedure. Our main endpoints were inter-rater agreement and reliability, which we evaluated for all parameters of the ELAACC score, and also for the combined score, and for all underlying continuous anatomical measurements where applicable. So, in this table, we see the distribution of the ELAACC parameters in the population based around the mean measurements from the raters. And the first thing we see in the distribution column is a great disparity in the distribution of the individual parameters. Some parameters, including the long Coumadin range and a short working depth, are prevalent in more than 50% of included patients, while others, such as the low ostium, indicating the short distance from the low takeoff of the ostium to the mitral valve annulus, being very rare. And our analysis for agreement was centered around absolute agreement, as we see in the agreement column, with expected chance agreement in brackets, and then around a Cohen's kappa analysis, which is a statistical estimate of agreement taking chance agreement into account, where a score of 0 amounts to no agreement outside of what could be expected by chance. And our reliability analysis was based around Kendall's tau, which is an estimate, a non-parametric estimate that tells us if raters are likely to move in the same direction when giving scores and making measurements. And highlighted here, we see the 3 best performing parameters being large ostium, large landing zone, and proximal septa, while a parameter such as the low ostium, which was exceedingly rare, performed not so well. We saw only a slight to moderate agreement, but that was likely also based around chance agreement being up to 90% due to rarity. And one of the main findings of the study is that some of the key parameters in pre-procedural planning are highly reproducible, and this was especially true for all the landing zone and ostium measurements, so the area, perimeters, and maximum and minimum diameters. And this also held true for transseptal puncture angles and our measurements pertaining to the LAA axis. And in these continuous variables, we measured our reproducibility, first of all by agreement, as we see here in our blind Altman plots with limits of agreement in red. We see very few outliers outside of the limits, and we see no tendency towards systematic bias, except for a slight proportionality bias in the area measurements, where we see raters tending to disagree more in very large measurements. And for the reproducibility of the combined score, first of all, we performed an unweighted analysis where we see only a moderate or slighter agreement based on the kappa analysis. But in this analysis, a disagreement of 1 point is given the same weight as a disagreement of 5 points. So we performed a linear weighting scheme in which the ordinality of the score was taken into account. And here we see a very, very high absolute agreement between the raters and a moderate kappa analysis, which was also likely driven by the rarity of very extreme cases of 5, 6, 7 points given. This also held true when we applied the color coding that we saw in the central illustration for the original paper, where we also see a moderate agreement for the stratification into simple, moderate, and complex anatomies. Finally, as a sensitivity analysis, we wanted to do a stratification of the ELAACC scoring by both raters and by inclusion site, in which we saw no significant change in the distribution. So, to summarize on the present study, we find moderate to substantial reproducibility for most individual anatomical measurements of the LAA. We find a combined ELAACC score with a moderate reproducibility by the kappa statistic, but high levels of absolute agreement in the linear weighted analysis. And we find that certain critical parameters, which are so important in device sizing, strategic planning in the pre-procedural stage, show substantial reproducibility, including all measurements at the ostium and the landing zone. So how does this work contribute to future efforts in the field? We find that CT measurements in general provide good, reproducible anatomical characterization of the left atrial appendage. And we hope that the efforts of this study may be able to build upon the growing framework for future efforts in the prediction of challenging cases and for subsequent clinical outcomes. And as the purpose of this study was centered around CT measurements, we have not done an analysis as to how our CT measurements correlate with TOE. And this is an obvious next step, and TOE also faces other aspects, such as interoperative reproducibility, which would need to be addressed in coming studies. But with the great role of TOE in many centers in the field, efforts to extend the validation study to this modality are important next steps. Perfect, good. So before letting the next presenter come to the stage, I would like to thank you all for your attention.
Thank you, Victor. So we will have the discussion at the end, and now Lorenz is going to present the clinical validation of this score and the path to the ELAACC score version 2.
Yeah, thank you very much. So our idea was then, after the reproducibility assessment, also to see whether or how useful the score might be to predict some endpoints. And of course, I have to acknowledge the people listed here and the ELAACC board members. And I must admit that the analysis took quite some time. We had a year, and we really just finalized the first results a week ago. So there was no, let's say, a possibility for everyone to look at it in depth. So this is the very first time we probably can discuss it. So the background is that, of course, what we want to achieve is a really complete LA ceiling, and we discussed that this is today, despite all the best techniques, not always possible, as we know. And what we want to avoid is device embolization, because it's associated with a 10% mortality periprocedurally. We want clearly to avoid peri-device leaks, because there is a continuous risk increase the larger the leak is. And there is also some data suggesting that deep device implantation leads to a higher DRT risk. And as you know, the ELAACC score is really aimed to anticipate, based on LA anatomical and functional characteristics, the risk, PDLs, DRT, and device embolization. And we do have this gap in knowledge that was not yet clinically validated, and therefore the aims of the study was to evaluate the clinical performance of the ELAACC score, and second, to derive and potentially internally validate alternative CCTA-based prediction in case that the predictive ability of the ELAACC score that is based on a binary approach. You know, we just had expert-based single cutoffs, but not a continuous approach, and we thought that we might aim to improve the ELAACC score in case we would not find it sufficiently predictive. So about the design, it was already said. We discussed and agreed upon during the ELAACC meeting in Munich which design would we or should we choose. This we decided mainly for practical reason to do it in a two-center approach, because as you can understand, the availability of CT in a large proportion is not that easy, together with, of course, the availability of the clinical characteristics and outcomes. And you need serial imaging methods of the same nature, in that case CT, so not only pre-procedure but also at the imaging follow-up time point. And we therefore included Bern and Aarhus. And each center provided data of the last 400 consecutive patients that received CT to plan and then to follow up the result. And this was between September 19 and December 24. As said, from both sides we included 400 patients, makes a total of 800 patient cohort that had a serial CT, and we assessed the pre-procedural CTAs and the follow-up CTAs, and assessed the clinical and imaging outcomes in a prospective fashion. Now, this is something, of course, we can discuss, but we have pre-specified the primary and the secondary endpoint for which the ELAACC score could be predictive, and as a primary endpoint we have chosen aborted procedure, death within 7 days, device embolization within 7 days, residual PDL, actually any PDL. We did not take a cutoff because there is evidence that there is a graded risk increase independent of that starts actually at 0, and this between 1 and 6 months imaging follow-up and deep device implantation. And we also had a secondary endpoint that did not consider deep device implantation, so aborted procedure, death, device embolization, and residual peri-device leak at 6 months. So these were the two endpoints for which we tried to make a validation. And the statistical methods were as follows. We anticipated an event rate for the primary endpoint of 40%, with and expected area under the curve of 0.7, and by the inclusion of 11 candidate predictors as per the ELAACC score, we would need 786 patients, and this is why we have chosen 800 patients. And in terms of statistical analysis that was performed, we evaluated the ELAACC score in terms of discrimination, so area under curve and ROC analysis and calibration slope. And then as a next step, so this first step is based on the binary ELAACC score approach, but then as a second step, we also used non-scoring parameters expressed as numerical variables to build an alternative prediction model by means of a full multivariable logistic regression model using the lasso method. Now, these are the results. You see here the overall column, Aarhus and Bern. As already said, I mean, this is representative of the activity at the two sites. You see, the average age is not the average age is not 80 but 74. 30% females. The average CHA2DS2-VASc is 4. Haspel score 3. Major bleeding is present in 50%. Some differences between sites, interestingly enough. And the amulet versus watchman distribution is also site depending, 30% amulet and 65% watchman. LA thrombus was present in 3.5%, and echo guidance was used in 100%. And there are general anesthesia in 10% with differences between sites, and sinus rhythm was present in 56%. As this was a CT-based analysis, the contractility could not be assessed. Now, regarding the primary and secondary endpoint, it occurred overall in 62% in both populations, the Aarhus and Bern, and the secondary endpoint occurred in 30%, and below you see the individual listing of the contributors to the end point. Now, if we look at the binary ELAACC score, whether the variables that contribute to the ELAACC score, you see them listed here, present or absent, and you see that there was that actually contributed, of course, to the primary endpoint. So if they contributed to the primary endpoint and there was a significant difference, this was true for large ostium diameter, which was defined in ELAACC score of more than 35 millimeter, and a long pulmonary vein ridge length more than 10 millimeter, and a proximal lobe. So these were the binary ELAACC score parameters that were significantly more frequent in patients that suffered from the primary endpoint. And here you see the distribution of the primary endpoint as a function of the ELAACC score, and what you note is, of course, that there is not an increase, but actually that there's actually a decrease the higher the score gets, which already tells you that the predictive ability is obviously limited. And if we then do the same for the secondary endpoint, we see that there are also significant differences. The large LA ostium, again binary, was significantly different in patients meeting the secondary endpoint versus not meeting the secondary endpoint. Large landing zone was significantly different, early sharp bend, and funnel shape. Tapering more than 30% was also significantly different. And if we look at the distribution of the frequency of the secondary endpoint according to the ELAACC score, again you see that it increases but then again decreases the higher the ELAACC score gets, again speaking for a limited predictive ability. Then we set out to develop a new ELAACC, or let's say a modified ELAACC score, taking into consideration all the ELAACC score criteria, but expressed in a continuous fashion, no longer binary, but really in a continuous fashion. And the criteria that we used are the same, are listed here: LA narrowing, LA tapering, landing zone eccentricity, working depth, pulmonary vein ridge length, mitral wall distance, and then finally also the fossa ovalis versus LA posterior and anterior angle as illustrated here. So these were the variables that we took into consideration in a continuous fashion. And the results were as follows. So regarding the primary endpoint, we were able to find independent predictors for that. First, LA osteo mean diameter was associated with a 1.75 increased risk increase for the primary endpoint, and pulmonary vein ridge length was also significantly increased, mitral valve to LA distance as well, proximal LAO lobe as well, but inversely. Remember that we had the implant depth as a part of the primary endpoint, and of course if you have a proximal lobe you try to place the device much more proximal. This is why the odds ratio is below 1. Then LAA tapering, LAA narrowing, and the fossa ovalis and LAA posterior angle was also predictive. So if we use this model now, you see the frequency of the primary endpoint according to the quintiles of the predicted probability, and you see that here we have now a pattern that we wish to observe, namely it is increasing the higher the score gets based on the continuous variables. And if we look what the impact is on the area under the curve, orange line indicates the binary ELAACC score and the blue line indicates the ELAACC score that is based on continuous variables, and we have area under the curve of 0.65, which is moderate in terms of predictive ability for this primary endpoint. And we also did the same exercise for the secondary endpoint that does not take into consideration the implant depth. And for that one, the following 4 variables were independently associated or were independent significant predictors of the secondary endpoint: LA osteo mean diameter, landing zone eccentricity, and the angle between fossa ovalis, the mean angle, and the anterior LAA angle. And again, if we look over the quintiles, we see that there is an increase with each increase in the continuous ELAACC score 2. That's what we would like to see. And here you see the impact of the predictive ability in terms of area under the curve. It is now 0.64, and this is again a significant improvement as compared to the binary ELAACC score. So if we want to summarize for the primary endpoint, including death, device embolization, anti-PDL, and deep device implantation, we identified significant predictors of that endpoint, namely the LA osteo mean diameter, the pulmonary vein ridge length, the mitral valve LA distance, the proximal LA lobe, and LA tapering and LA narrowing. For the secondary endpoint, that is not taking into consideration the implant depth, the following parameters emerged: LA osteo mean diameter and the fossa ovalis LA mean angle and fossa ovalis LA anterior angle. So the study limitations are that, of course, you can debate the selection of the endpoints, mainly implant depth, because as you have seen, the endpoint occurred in 60%, and that, of course, you can debate. LA contractility was not assessed, as this is not possible by CT. The study was conducted at high volume sites with low event rates, and there's a lack of external validation. But in conclusion, the original ELAACC score based on categorical variables shows a limited discriminative performance in terms of predicting the primary and secondary endpoints that we have pre-specified last year. The prediction models incorporating the individual ELAACC score criteria as continuous variables significantly improved the prediction of procedural outcomes, but despite the improvement, the model discrimination remains moderate, suggesting that we still have room to improve it. I like also to make a comment. So despite the limited predictive performance for the investigated outcomes, the primary aim of the ELAACC score, of course, was, and I cite here what we wrote in the paper, should be a user-friendly and effective in distinguishing between complex and standard LA anatomies, facilitating a common language among implanters and imagers, and this, of course, still is fulfilled. Thank you for your attention.
Thank you, Lorenz, an amazing presentation and amazing work. And now we begin the discussion. I think that Jans wants to say something, and I invite Adel to lead the discussion.
No, thank you, Lorenz. I especially like the last sentence because the primary aim with the ELAACC score was really to create a common language because we talked about those 4 categories of chicken wings, etc., and we needed something much better. So that was one of the main purposes. The second purpose was to really try to predict a complex and challenging procedure. And therefore, I maybe think we have been too ambitious in choosing the endpoints here in this analysis, because it really comes down to whether 12 different parameters can predict PDL. And I think that's a very, very difficult task. And I think the parameters that finally comes out related to ostial diameter and eccentricity means a lot of sense in relation to PDL. But what I also would like very much to see is what is procedure time, what is number of devices used, what is number of recaptures, etc. Some parameters that can really enlighten us whether the implanter was struggling or not. And I'm not completely updated whether you did all that stuff as well, but and then again, it's a little bit problematic that we are 2 high volume centers that tries to evaluate the score regarding procedural complexity. And also, there's this built-in paradox that if you really spend time on your CT scan and understand the anatomy and your ELAACC score, then you have spent the time on your pre-planning in order to achieve a good result without complications. So it's not that easy to validate this score, but I think we have been too ambitious with going directly to PDL and have the ambition to try to see if 12 binary parameters could predict those PDL. And also, what really could be interesting was also if we could get a signal on DRT, for instance, and I mean the PV-rich length is also a little bit controversial. We set the limit here for 10 millimeters, but you know, many anatomies you can simply not, for instance, place an amulet disc all the way up to the pulmonary ridge. So I think there's a lot of limitations. But I would really much like to hear your comments on fluoro time, procedural time, a number of devices, number of recaptures, etc. Yeah, please.
So I could not agree more with your comments, of course, but we had to start at a certain level, and as you have seen in the presentation of Adel, PDL was mentioned as main consideration everywhere, so not validating PDL really would not have made much sense. Regarding all the parameters that are an indication of complexity of the procedure, that is captured. That's the good news, but we still need to look at it. We were quite stressed to make it for this meeting, so we had not yet time, but of course I agree with all the points, and we should not forget what the initial aim was for the ELAACC score. But I think it's already, to me, it was not so much surprising that we are unable with a binary anatomical score to predict much, but I was surprised that it is possible when you use continuous variables based just on anatomy. That was quite a positive surprise to me. And I think if we would then go the further step and even combine it with a patient profile, I think can be a nice outcome at the very end.
Yeah, there are several questions in the audience. Lisbeth?
So, yeah, thank you. It's very, very interesting. I think I was already a big fan of the first ELAACC classification because indeed it really gave us a definition. But there was one thing that I was missing, and that's something you address now, and sometimes it's better to see it on TOE, which is the spatial position of the ostium of this left atrial appendage. Is it more inferior or superior? Is it more anterior or posterior? And that in combination with the position of your fossa. But I didn't really understand now, was it like a significant predictor or not?
Yes.
This spatial relationship, yes.
Yes, it was. It emerged for both endpoints as an independent predictor, indeed.
Yeah, that's very interesting because specifically it's easier to see on TOE, so it would be good to combine both information points.
There are another two questions. So, Jordi?
There is a microphone, the gentleman here from UK.
So
you have a micro.
To be honest, it's a topic that I think that we can discuss for hours. But I want just to point out that actually we did a study that actually the paper is already accepted at our intervention, but it has to be out very soon. That we do like a similar study with similar variables. Some of them are here are part of the ELAACC score. And I want to point out two things. One, I think that even CT has, or you cannot assess contractility, you can assess it with the atrial fibrillation or typed atrial fibrillation. So it's a problem that we had. We had the type of atrial fibrillation to assess contractility, and the ROC curve improved a lot. So we obtained a 0.8 almost of ROC curve to, try to predict this kind of DRT. And the other thing is, for me, it's a mistake to assess pulmonary ridge length alone, because it's actually very related with contractility. Actually, last year in the ELAACC, it was a presentation showing a Watchman case. They had like a very deep Watchman, but they have like a very, very high contractility. So then what this supposes is that the washing in that area was like very, very nice. So what I want to say or to explain is that you can have like a very deep position and a deep or a high pulmonary ridge length, and this patient will not develop DRT. So I think that there are two concepts that actually are quite linked.
Yeah, but Jordi, at the end, you need to standardize. I mean, in the same patient, what it's better, just to have it, same AF patient, what it's better, just to have it deep or not deep.
So in the ideal, we have ponderized it.
Not deep, I mean that maybe the sinus rhythm and the high velocities may mitigate.
Exactly. So I think here, and I agree with Jens-Erik, this is 2 ambitions and you have to go in step by step. But the other thing is that you cannot give the same weight in every variable.
But it depends. This ELAACC score, it's just made under the definition of optimal, implantation. Optimal means not too deep to prevent DRT and without leaks, and of course without embolizations. So every single parameter, for example, tapering means risk of embolization, but doesn't mean the risk of DRT. The risk of the reach, it's just made for it's kind of risking you just to put it not too proximal.
I fully agree with you, but then you always will have a part of your study or a huge part of patients that will not fulfill, your score. Do you know what I mean?
The score is fulfilled.
Sorry, we need to move. There's one question. He was since the very beginning.
I think, can I congratulate first for developing this score? I think it's very useful. First question for the developing team is, when you put the first ELAACC score, did you consider the characteristic of the septum? Because the coaxiality is very important. Even if with the ELAACC score of 0, if you have a thick septum, smaller septum, or previous device, you won't be able to get a good implant. So was it considered and didn't include, or what?
It was considered during the discussion, during the first ELAACC meeting, but we decided that it will add more complexity to the whole scoring, which is already complex with 12 variables. So we decided not to include transseptal. Although I agree that it's part of the complexity, but it doesn't say anything about the anatomy of the appendage. So we wanted to keep something really focused on the challenging anatomies.
But if you are thinking of an optimal implant, I think maybe in the future you may have to consider. The second point is regarding the ELAACC scores 2. I think like chicken wing, acute angles, we always know they are challenging cases. So if you just exclude those and goes to a continuous variables only, I think that may be not serve the purpose, because I think all these parameters are equally important. Maybe the statistics that we use or what we want to do didn't match it. That's why we didn't see the pattern. But I think the continuous, what we see here, I agree statistically and good illustration, but I don't think we can ignore the parameters already shown in the first score.
I think I finished with this comment, but it's difficult to validate those parameters, because if it's a very complex appendage, you anticipate even more the complexity. So probably you end up with a good result because you have anticipated all the complexity of your case. But I think this is a very nice first step, and we need to continue to search about how to validate. And I think procedure efficiency is probably the way to go. How many catheter manipulation? Maybe for the sake of time, I will move to my presentation.
Yeah, we have to, because we have to. Sorry, we have to interrupt because we have to be at dinner in 15 minutes, and we don't want to miss your talk. And the poll at the end is also important for the consensus. So please, sorry about that.
Okay. Can I read my slides, please? So I will talk about something relatively different from the anatomical score. So this is the path to an ELAACC clinical score. So why the field requires a clinical risk stratification score, okay? So we have, as we have seen, we are talking today about the selection of the patient, okay? So we know that there is an early mortality problem. So there is high 1-year all-cause mortality in real-world LAACC registries. So basically the patient will die before driving any stroke prevention benefit, and this is called futility. So the procedures carries a risk but insufficient time to benefit for the patient. So Closure AF was a kind of wake-up call. We know, we have seen this trial today, which was nicely shown by Karsten. So LAACC was not non-inferior to best medical therapy. There were more cardiovascular death and bleeding in the device arm, and you all know these sentences from the editorial. LAACC failed to fulfill its promises, at least for older, frail patients. Best medical therapy should remain standard for older patients. So the key message from the editorial was the procedure is not for everyone. So the answer that we have to tackle here before the dinner, if you have still time, we need to validate a clinical risk score. So we know the Euroscore 2 for cardiac surgery, we know the TRI score for tricuspid repair, we know the STS Euroscore 2 for TAVR, and we need some kind of a new clinical ELAACC score to identify which patients are at too high risk for LA closure. I think we need also to define a threshold for futility, which is not easy, honestly, and we need this future scientific validation. So we have to learn from analogies from other scores. The TRI score model, as you know very well, for tricuspid defines a low risk, intermediate, and high risk population for surgical tricuspid replacement, giving a very high mortality in the high risk, and this drives the therapy between the surgery and the transcatheter or medical treatment. And I think the LAAC field needs its own equivalent score. So the aim here, if you still have time, or we do it tomorrow, but is discuss its weight, some kind of relevant clinical parameters from published evidence, define a framework for open discussion, define a futility threshold when LAAC should be reconsidered, it's not easy, and plan a scientific validation. So just to give, because we've discussed a lot about the mortality, and we said closure F is a high mortality. Yeah, okay, but if you look at some other registries, like the Evolution or the Amulet Multicenter Registry, we look at the 1 year mortality, it's not low actually. Okay, we have talked about Champion, we have talked about Option, very low risk population, but if you look at some other registries, we have quite high mortality. I just focus on closure F, was already presented by Karsten, but I just show one multi-center registry from Spain and Canada, and this was published like 4 years ago or 5 years ago, and they showed that actually in a multi-center registry, unselected patient, the mortality at 1 year is 15.5%, which is quite high, which is the same or even more than in closure F. And these are centers that with operators that you can see here, and we see that the annual mortality was not changing over the years. From 2009 to 2019, which was the inclusion period, you see that the mortality is extremely high and go below, a little bit below and far above 10%. Very important, you see that mortality was not associated with procedural success or the antithrombotic treatment after LAAC, meaning that it has no impact. So you can do a perfect procedure in the patient, but the patient can die very early after the procedure. So they have found very important independent predictors, the age as a continuous variable, but here you can see as a dichotomized cutoff, the BMI, the presence of diabetes, the EGFR, so the renal function, and the fact to have heart failure as a previous history, not about ejection fraction, but previous heart failure. So all of these parameters independently predicted mortality in this registry. And very importantly, if you start to add many risk factors, for example, you go up to 2 risk factors, you have a 1 year mortality of 16%. 3 risk factors, 1/3 of the patient are not alive at 1 year. 4 or 5 risk factors, half of the patient are dying at 1 year. So this already gives you a threshold for futility. The same group from Spain and Canada, they assessed a frailty score, the essential frailty tool within, again, a multi-center registry with 452 consecutive patients. You see the mean age, 76-year-old, 1/3 of women. And so they assessed frailty in a prospective fashion. And this is a very easy tool. So there are a lot of frailty tools that have been published. But it is actually, so you have like this 5-chair rises test. This is less than 15 seconds, it's 0 point. More than 50 seconds, it's 1 point. And unable to complete is 2 points. The fact to have cognitive impairment or not, and this was defined as a minimal mental status score of less than 24. 0 if it's not, 1 if it's present. The hemoglobin level with differences between male and female. So if it's low, you get 1 point. And the serum albumin, which is a testimony of the patient cachexia or not. And this was already validated in the TAVR field. If you look on the right, when you had a high EFT score, it was associated with a very high rate of 1 year mortality in the TAVR field. And they show, the same group show again that when you use this frailty score in patients undergoing LAAC, you also predict mortality. So patients that had an EFT score of at least 3 or more than 3 have a very high mortality at only 1 year. So 32% versus 7.7%. And this is like there is a stepwise increase And if you get like a score of 5, then again you have an extremely high mortality. The distribution of the different parameters you can see here. So for example, the inability to complete the 5-chair rises was one of the most common one, including, and the other one was the hypoalbuminemia. And if you add this frailty score on top of the classical clinical risk score, you really increase the accuracy of the prediction of this model. So you take the clinical risk factors and you take the frailty scores, and this adds really a very important prediction for the patient. So just to open up the discussion, so what kind of other predictors we can take into account? So age, either as a continuous variable, it was shown in the multi-center registry to be significant, but probably a cutoff would be more appropriate. In the Amulet multi-center registry, which was published by Chavi, there was at 2 years, there was a 20.3% all-cause mortality if the patient was equal or above to 80 years old, as compared to less than 10% in patients less than 70 years. So age alone, does it define futility? It's not clear, but age and comorbidities probably increase the risk. Sex-based considerations, so there are many studies showing that actually sex is not really something that will define the mortality. For example, when you compare in the US registry, when you compare the benefit of LA closure as compared to DOAC, there was no difference in terms of being a woman or a man. EGFR, this is probably a strong predictor. It's not an absolute contraindication as we have seen today, but probably it should be included in the clinical score. Which other variables? Reduced ejection fraction, LV dysfunction, it is something that independently predicts mortality. Diabetes, especially if it's insulin dependent. Hemoglobin and albumin, but these are already part of the essential frailty tool. The presence or not of previous major bleeding. So this is some kind of paradox because major bleeding is both the main indication and the risk factor. Maybe we can subdivide into prior intracranial hemorrhage, which probably gives the highest risk of mortality, and other cause of bleeding. But we know that the recurrence of bleeding is also a factor of increased mortality. The BMI, and we have to define the threshold. And the CHAS-VASc and ASBLED probably identifies patient at risk, but not probably the patient that will have a higher mortality. So very quickly, what kind of variables we can integrate into the score. So I've shown you the frailty score, the EFT more than 3 is a strong predictor in the multi-center registry. The presence of the history of major bleeding could also be a strong predictor, LV dysfunction, diabetes, and some other parameters. And what we want is to end up, this is just like a future proposal with some kind of quick reference calculator that can predict mortality in patients undergoing LAAC. And we could define like a low-risk population, an intermediate one, and a very high risk where actually the procedure is totally futile, and we should probably not consider this procedure in the patients. So which variable we should include, how we can implement it in a practical, from a practical standpoint. We need something that can be calculated easily at the bedside of the patient. Which tools are feasible across all ELAAC or all centers for a multi-center registry? At what point in the LAAC pathway should the score be calculated? And should the score be a hard stop or just an advisory recommendation? And I think, of course, we need to validate, and this is a great task to validate the score, even if we define what will be the variables. So my key messages, so 1 year all-cause mortality of LAAC is non-trivial. It's more than 8% in many registries, up to 15% in the very elderly. So closure AF is a wake-up call. LAAC is not for everyone. Patient selection will determine the outcome. The frailty score, it's a strong single predictor of 1 year mortality, and we need a dedicated clinical ELAACC score as a next step on top of the anatomical one. And if we still have time, I don't know if it's not, or we keep that for tomorrow, but we have to define the variables. So I've prepared a vote. I don't know if we still have time to do it, or yeah, we go for it? Okay. So can we show the vote, please? Just to know which variables you want to include in the score, and that will be part of the consensus. Of course, then we need a clinical validation. So the first one, the first question is: do we need an ELAACC score? Yes or no? So okay. So everyone agree that we need a clinical ELAACC score on top of the anatomical one. Okay. Okay. The next, please. Oh no, sorry. Oh, sorry. Excuse me. I thought everybody.
I think you need to go through all the questions until it's shown. That's the problem.
Oh, okay.
You can go through the questions.
Oh, okay.
I have a comment, Adel.
Yeah.
First, while people are answering the questionnaire, I think this is one of the most important presentation of the day, as I told you. We are for the ELAACC, and we said that this year the theme is about patient risk profile. And I think if we go and if we want to improve our anatomical score, we have to go to the clinical one, as it was done for the TRI-score, for example, where some clinical and biomarkers and imaging we already have, are there to scale the procedure, the complexity of the procedure, and what we did is really great with the anatomical score, but then we can go to the prognosis of the patient. And if we want to say, okay, but closure is a problem because the patients were not good, we have to define what is a good patient. And we cannot just say, Carsten, you did bad, you are, I don't know, you did what you did.
Please don't.
No, I don't do that. I just say that we have to define, we have to have some objective criteria, and this is going to the good way. And hopefully you have the frail study that Xavi did with Pedro and all this team and some clinical variables. And I think it's really important to define the good one and then to scale everything and then to define this is a champion-like patient, this is a closure-like, etc.
If I may have just one comment, Ian from...
Yeah.
I think the way to move forward is you first need to gather a lot of variables that you put in a very large database. That's your discovery cohort. And then you define your endpoint, mortality or patient selection. And then you just run a model, like Lorenz did, and the model will determine the weights on each variable. And some variable will be redundant and will disappear. But the way, like we will do now, we will give 2 points, and that will not work. It's not a scientific approach.
I didn't put any points. It's just which variables we are going to assess. That's it.
Yeah, we are going to measure. We have to measure and put it in a database in the ELAACC. And once we have like 5,000 patients, we can link it to an outcome. And then we have like a kind of Euroscore. And the larger the cohort, the more variables we can develop. Because the degree of variability will depend on the total number of patients. If you have 800 patients, you will have like 5. Yeah, but if you have 10,000 patients, you might have 20 variables.
Of course.
And that's the way to move forward. And then once you have a discovery cohort, you need a validation cohort, and then it's online. But yeah.
Yeah, I agree. But anyway, you need to search for some variables that you think will impact the outcomes. Of course, you need a scientific validation, but at first we need to agree on first the cutoff of what will be.
No cutoff. The cutoff will be determined by the database. Yeah, now we need to discuss which data point are we going to measure. Like the frailty, but the cutoff, you need to put it in a linear way, and the cutoff is not important. The variable we will measure, that's what we have to discuss.
Yeah. I think, Karsten, thank you very much for this important...
Just one short comment. So what we did right now was to develop a score who benefits from MCS. And how you do it, you have a derivation cohort, and there you have your characteristics, and you showed how some people got some characteristics that were predictive for outcome, but usually you should have a huge database where all these people of different risk are in, and then there you can statistically attribute certain characteristics with such and such importance, and then you go into your...
Yeah, of course.
So because if we look now and we say, well, we think this is this, I don't think that leads us to where we actually want to go.
Yeah, of course.
Jens Erik.
As I see it, we are talking now about three different ELAAC evaluations. The first one is an ELAAC anatomical classification, complexity score, and I feel we still need to validate that with procedural times, recaptures, number of devices, etc. Then we are talking about another prediction, and that is the prediction of PDLs. And instead of trying to derive that from the original ELAAC classification, it would be better to look at cases where we actually see PDL and then go back and find the most relevant parameters that will predict PDL. I think that will be the way to go, and I think it's very, very important if we can have some tools to evaluate or predict PDL. And then the third one is your suggestion, which I find extremely important, namely to have some kind of systematic evaluation of futility and frailty. So that will be a third kind of evaluation. But right now, trying to mix an anatomical classification with prediction of PDL with also clinical outcomes related to old patients, it will simply be chaos. I think we are talking about three different things.
Of course, but today we'll discuss a lot about which patient benefits from the procedure, and so we have talked a lot about mortality. And,
but we should just work on those three columns.
Yeah, one question there.
I'm really impressed with particularly the data set that came at Aarhus and Bern, and that as we're putting together, it also impressed how much hard work it has taken to do what you've make the statements that you've been able to make. It seems like to me that you're developing a really rich database that would be very good for machine learning model, and that which using things that I don't know anything about, but beginning to learn about AI models, so that with the Bern Aarhus data set and correlating anatomic features with clinical outcomes, I think that someone much more sophisticated than I could start using that as a machine learning model to develop, to really come out with things that probably will surprise us all. And afterwards, there's a lab at Columbia and then in New York, and also one at MIT that I've worked with that might be of help to you.
That's a very good comment, of course.
Lorenz, yes, I agree completely with Jens said. The net benefit of the procedure is a mix of aspects. In one hand, we have the procedural risk, and we are going in the right direction with the ELAACC classification, because now we are improving the quality of the classification, and at the end I am confident that we will be able to define the real risk of the procedure. In the other hand, we have the clinical evaluation of the patient, and with the frailty, life expectancy, and so on. But the model is a complex model, and I think we have to address separately each one of these aspects. Probably machine learning, I'm not sure that machine learning is enough, probably deep learning model be able to integrate both the aspects. But for the data collection and for data analysis, I think we have to address each one of these parts separately. After that, probably deep learning model, I'm not a very expert, but I think it could be one of the possible solutions.
Yeah, I totally agree. Just one quick comment. I agree that we should develop this score or whatever based on the database, as you said before. The problem is that some of the variables that you propose are not included already in the ELAACC registry. Mm-hmm. So maybe we need to find some kind of agreement in which variable we should measure or whatever, or integrate, because this should be integrated in the ELAACC registry in order to validate if they work.
This is also, I mean, scientific validated by previous registries. I've shown two registries showing that frailty was an independent predictor. So it's good when you have something already validated that you take into account what was shown to be predictors. Otherwise, if you take just...
Yeah, but as he said, I mean, the ideal scenario, you have all the variables in the world, just including the registry, then you develop the score based on that. But we don't have all that variables including the ELAACC registry. So maybe we need to have a consensus with variables we want to include prospectively in the ELAACC registry in order to validate this.
And what will be the cutoff for futility? Yeah. What is the 1 year mortality that the people here will consider as a contraindication? Or it's not clear for me. Is it like 30%?
I think that the poll makes sense.
I think we have time for 2 final questions. Tom and you, maybe you first. Because
So this is maybe an opportunity you combine with the US data. They have 500,000 patients. So why can't you do a combined project and, as he exactly said, run a model to identify the variables which predicts and use those as to develop the ELAACC registry?
Yeah. Just before the talk, I saw that the US registry, they also assess frailty, but I had only the 45 days outcome, but it was also predictors of mortality at 45 days already.
Final question from Tom.
Well, also for me, I think super important. Congratulations on doing this, and I share the sentiment about the US database to find parameters. The other observation I had was you're absolutely right that futility is one of the things killing the therapy. The other thing, of course, is not just midterm mortality, but acute procedural issues. And beyond the implant itself, do you see a way to capture elevated risk for procedural complications? For example, I'm surprised that you don't do BMI on both sides, low BMI, but also very high BMI as a surrogate for potential for high risk of access complications, particularly small atria as a surrogate for potentially more high risk punctures, stuff like that. Do you see? Because I think that's the other component that's killing the therapy. If we look at closure AF, it's not trivial.
Honestly, today is just a proposal for open discussion. So everything that we said here will be integrated. As you said, I'm just proposing some variables just to open the discussion. So it's just a project. Nothing has been done. It was just to go towards this clinical score. So I think we all agree that we have to go for it. Fully agree with Jan that we need a very large prospective data set to validate. So it's going to be a long way ahead to have this clinical score ready, because I think retrospectively it's going to be difficult. And so, yeah, let's go for it. And I don't know if you can still see the rest of the voting.
Yeah, exactly. We're very lucky that we're in Italy, so the kitchen is closing late. But nevertheless, I think we should slowly come to an end because we have to meet afterwards, immediately after the meeting at the lobby. Because the dinner will be served in the hotel, but we meet at the lobby immediately afterwards. Okay, but I think we should, before that, go through the answers.
Yeah, okay.
And then this would be the final step of today.
So age should be included, of course, and then of course we need to define the cutoff. It's just informative, So 20% is I mean, there's like it's not a strong consensus. It's like, okay, so at least 10% is not a limitation. So 20% of mortality at 1 year is already something that we should reconsider the therapy.
So in conclusion, age with a threshold, renal
LV
dysfunction, LV function,
frailty,
but not diabetes.
No, and CKD.
And body mass index.
Yeah. And then let's try to validate that. Okay, I think I'm finishing. I'm concluding this very nice day. Thank you very much to everyone. It was it's not the story is not yet finished. I think we have a lot of work to do, and I like very much those open discussions because that's the only way to reach consensus. So thank you very much. Have a great dinner, and thanks a lot.